Good morning, everyone, and welcome to today's Recovery Summit presented by St. Clair County Community Mental Health with support from the St. Clair County Health Department. Today's presentation is CMH SUD Services, MAT, and the Recovery Court. Before we begin, we're going to go over some general reminders. I know a lot of you have heard all of these before, but in case there's anybody new, please use the chat feature for all questions or comments. Our presenters will be answering questions as time allows. Today's presentation offers one social work CE and one McBath credit. If you are requesting professional credits, you must remain on the webinar the entire time for credit. If you lose connection, please reconnect as soon as you're able. A survey will pop up following the conclusion of the webinar. Those of you that are requesting social work CEs, a completion of the survey is necessary. And now I would like to introduce today's presenters, who are all current employees here at St. Clair County Community Mental Health. First, we have Sherry Jessup. She is the SUD and DBT Department Supervisor, and Alexis Hadwin is the clinical coordinator for the SUD department. We also have Courtney Warzinski, and the nurse. She's the nursing coordinator, and Megan DeStefanis is the registered nurse. Right now on the screen we have Sherry and Alexis, and they are going to start us out. Welcome.
Good morning, everyone. Happy Friday. I am Sherry. I've probably seen a lot of you in the building. So I am over the substance use disorder department, better known as the SUD program. Alexis is my coordinator. I wanted to give you a little background because Alexis is going to focus more on the recovery court. We're here pretty much to be able to see people that wouldn't otherwise fit into CMH services. So we're looking primarily at people with an SUD disorder who don't really have much of a mental health history, or nowadays, since we've changed some things around, we just try to not have them have a mental health history, but we can take them. Outpatient services provides people with co-occurring services, which a lot of times is a good option. And then we have the IDDT program with more severe stuff going on. So we're just trying to catch those people who otherwise couldn't get services here, and we need it in the community. So how we're set up is our program, even though we're part of CMH, we are considered a contract agency for Region 10. So how we do things work a little bit differently. You would have to call Access Services and tell them that there's no mental health history really. They would authorize for somebody to come in and do an intake. Region 10 goes ahead and schedules them with us, since there's also different credentialing requirements for our program. And that is how they come in for their first intake. And then if they meet criteria for services, we get more authorizations. All of our staff are McBath credentialed, or they at least have a development plan. And that's a requirement of Region 10 for us also. So that at the same time limits some of the services we can offer, because to attend groups, it has to be one of our staff providing the group.
All right, folks, we should be all good now. Hopefully that volume and everything is a lot better. If someone wouldn't mind just putting in the chat, if you can hear us better, we would greatly appreciate it.
Way better.
Thanks,
okay,
Nicole.
Awesome. Thanks for the crowd for being so flex on things again. Fridays happen, right? So I'll go ahead and turn it over to Alexis and Sherry again. And you have the floor, ladies.
Okay, now to remember where we were. So we talked about the SUD program. We're trying to fit something that otherwise people couldn't get services at CMH. So outpatient does see people with co-occurring disorders. Everybody's trained for that, or getting trained. Then we have the IDDT program with more severity. We're meant more for just substance use disorders across the board. We are all McBath trained, or we have a developmental plan, and all of our authorizations and the rules that we follow go directly from Region 10. So we do offer individual therapy. We also offer groups, but our groups are limited at this time because it needs to be somebody from our department running the group who has McBath credentialing. We offer medication management, nursing, medication assisted treatment. And just so you know, we also have all recovery court people under us. So sometimes those rules get a little blurry because recovery court people can have more of a mental health history if they're taking part in recovery court. We also, like I said, we have medication assisted treatment, but the outpatient department and integrated dual diagnosis treatment can also refer people to the medication assisted treatment. So we'll talk more about recovery court in a minute. We need to, something that has gotten blurry along the way too, is a lot of times, let's say people go into remission from their substance use disorder, and then we discover that there are more mental health needs. At that time, we cannot transfer people to the other departments. And vice versa. If you realize somebody is more substance use, they cannot be transferred to the substance use disorder department, because we actually have to discharge the person. And then once they're discharged, most of our staff do try to help them call access that day because it gets confusing, and set them up an appointment with central intake. Central intake does not see our, does not do intakes for our people coming into services. It's the clinicians who have to do it. We don't do the traditional biopsychosocial assessment that's done for the rest of the departments. We have to do the ACM continuum in a different system. As we talk about that, we're also under federal guidelines for recipient rights. So we have some stricter rules around people's privacy, confidentiality. So if somebody does discharge from us and then we get them with access, they go through and open to another department, the other departments do not have access to their record while they were in the SUD department. It's just a whole different thing. Our program is really meant to be short-term for the most part. So our hope is that people are doing better. Once they go into remission, we can no longer get authorizations unless they're taking part in recovery court. Once they go into remission, if they have a mental health diagnosis that is primary, or they just have a diagnosis that's in remission, and we can't get authorization for that. So the majority of the people that we see are going to be short-term people who couldn't get services elsewhere. We also do some assessments for people who are on parole. These people have spent longer in prison, maybe they haven't used in years, and this is, there's a contract with Region 10, so pretty much they would go through the ACM continuum, and we might do an assessment and offer them services, or we may realize they've been in remission, and we may just write them a letter saying that they don't meet criteria for our services. That way, then the person can just take it with them to their parole officer, because a lot of times they can't get off of parole until that's done. We don't have a contract with the courts. We do not do assessments for people who have gotten a DUI. Those are some different agencies. There are a couple in this area that have contracts, and it's a totally different assessment that comes along with drug testing and some different things. And they give recommendations for the court. That is not something that we offer. And usually I think that is something that someone has to pay cash for. I think, did I miss anything, Anna?
No, I think, is it okay to say like who those agencies are that do the DUI testing? Because I feel like that would save some folks some time going through that process.
I only remember Impact is one. Does
Catholic Charities?
I think Catholic Charities may. I think at one time PCC used to, but I'm not sure that they do. But if you ever have any questions, you can always call me. I do have a list in the office. I think we all have a list. Another thing is people, because everybody has to be credentialed, we have to be careful and make sure that the prescribers are authorized through Region 10 also. It's just a totally different thing. But I'm going to let Alexis take over and talk about our recovery court program.
Hi, good morning. My name is Alexis Hadwin. I work with St. Clair County Community Mental Health. I'm the clinical coordinator for the substance use program and the recovery court program, and then the main therapist for the recovery court program. So for those of you who are not sure really what a recovery court program is, it is a treatment court aimed to reduce recidivism and substance use by sentencing individuals into long-term treatment that's monitored by the court. So it's a diversionary program through the treatment court, and We began in October 2019, right before COVID got hot and when lockdowns began. And the original grant funding was through the Michigan Office Highway Safety Planning and Drug Court Grant Program. In the beginning, we were limited to driving related offenses due to the specifics in the grant. But since April, we were awarded the opiate settlement funding, and we were able to double the amount of participants from 15 to a cap of 30, and we're able to accept referrals for any charges now. Of course, there's some limitations within, however, you can send a referral and it wouldn't be denied off the start just due to the charge. Currently, we have 26 participants in the program and 18 people have graduated the Recovery Court program. So who is on our team? So the team we have is Judge Don Monahan. Abby Armstrong is our probation officer and our coordinator and keeps us all online or in line rather. And Sarah Grout is our defense attorney. Dawn Higgins is from the DRP. And then we have a rotating member from the prosecuting attorney's office. And our treatment providers from community mental health is, we have a certified peer recovery coach, Chris Apperson, and a case manager, Nicole Quain, and then myself as the main therapist. So, and that's the team that kind of comes together and takes care of things. So how do you get referred to recovery court? So there's a referral and anyone can do a referral. Probably the most efficient way would be to have an attorney do it. Your attorney do it after arraignment, get it right over to the probation office and take care of that. All the attorneys are aware of the referral process and have the form for that, or they can contact the district court, Abby Armstrong. She can get a referral form to you, or if you work for community mental health, I can talk with you about those as well and get that form to you.
How would a person ask for it who's not in any services?
Probably your attorney is the best way,
Okay,
because you're always linked with an attorney from the get, right after you get charged and arraigned. And at arraignment, I would just say right away, like, I'd like to be referred to recovery court, or can you tell me a little bit more about this? Welcome to call community mental health and ask for myself or Sherry. And we can kind of get you some information on that too and see if it's a right fit for you.
can I ask another question in case anyone's
Yes, you
asking
can.
or thinking it?
I love it.
So we have, because Judge Tomlinson is over mental health court.
Correct.
What if they decide that the person's mental health needs are higher than the substance use needs? Like how,
Yeah.
what would happen?
Great question. So that's kind of one of the positives of, I think, of having like a clinical team or a clinical person on the team is to kind of evaluate and review the charts and review the person, talk with the person directly. Last week I talked with an individual directly that was in the mental health side of treatment, and we found that the needs were primary substance use. The mental health diagnosis was more mild, things going on. So we canceled out and closed out for the mental health side and then switched him over to the SUD side. And this individual is going to be in recovery court coming up soon.
Okay,
Does that answer that?
Yeah.
Okay. And then, so once we find that the referral comes into the probation office and the probation officer does an assessment with the individual, and it's called the risk needs assessment. And once Abby completes that, she brings it to the team, and then we kind of decide that whether it should be accepted into recovery court or closed, denied, and go through traditional probation. Or if it seems like it's high mental health needs, I'll kind of step in and say, this individual looks like they would be an appropriate referral for the mental health court. So linking them probably with a referral for that. So individuals are sentenced in, when they're accepted, you're sentenced in for 2 years of probation with a minimum of 13 months. And the recovery court program includes graduated sanctions and incentives and therapeutic responses. So any type of behavior will always generate a response every time. So whether it's positive behavior, you're having a recovery behavior related issue, or you're having a not so good behavior issue, those all are going to generate a response from the team and from the court. So sanctions would be to decrease or stop a behavior. And an example of a sanction would be maybe community service, X amount of community service days, an increase in your testing, or possibly like increasing your court appearances. An example of a therapeutic response, and therapeutic responses would be where an individual maybe is struggling with their recovery and we want to treat that behavior. So that might be to recommend treatment. So going to detox or residential and detox, maybe an increase in your appointments with your therapist, seeing a case manager, for your needs there, or the peer recovery coach, increase in meetings with that. 90 meetings in 90 days is also a big one that we like to use. It's really beneficial to individuals. And then we have incentives. So incentives increase or start a behavior in the program. And so a simple incentive is like just an acknowledgement from the judge, like having a judge sit across from the bench from you and saying, you did an amazing job. Like, we are so proud of you. Great job. You worked so hard. Like, that just like touches the soul. It's people really like that. I love it. I love seeing it. I think it's a really cool thing. And then we have other things like other incentives, like paid incentives with like gift cards. Okay, so then there's the 3 phases in the recovery court program. I'm going to talk about those phases individually. Phase 1 would be minimum duration of 3 months in the program. And the goal during this time would be to discontinue the substance use and stabilize the health of the individual. And required during this time frame would be weekly court review sessions. So you're coming to court every Monday, and after court every Monday, there's a group to attend as well. And then you're also attending weekly counseling sessions, weekly group sessions, weekly certified peer recovery coach sessions. Drug and alcohol testing will be at high random frequency at this time. You'll be doing 2 to 3 recovery meetings, 12-step format or other format. If Dharma's your thing, we'll do all those groups too. That would be acceptable during that time. And then you're finding a sponsor within 30 days and doing a journal weekly. So that's phase 1. So phase 2 would be a minimum duration of 6 months. And during this time, the goal of the program at that point would be to remain drug and alcohol free and maintaining full employment. So we're looking for jobs. We're searching if an individual is interested in going back to school during that time as well, we'd encourage that. And what's required during that time frame. So we're attending court bi-weekly now. So every other week you're coming to court, every other week you're coming to the group session after court. And you're doing weekly journaling still. We're doing therapy and certified peer recovery coach sessions as indicated by your treatment plan set up through community mental health. You're doing drug and alcohol testing, still rocking strong with that. We're going to be slightly reduced at this point though.
Will it still be random?
It's still going to be absolutely random. Yes. And 2 to 3 recovery meetings weekly. And the 2 to 3 depends on if you're working full-time at night. If you're working full-time, 2 is mandatory. And if you are not working, it'd be 3. And you're welcome to do so many more than that. So the requirements to move to phase 3 would be a minimum of 180 days in the phase, minimum of 90 days sober, obtaining a sponsor, in 60 days without a program violation, and that will get you into phase 3. So phase 3 is a minimum duration of 6 months. And during that time frame, the goal of that period would be to remain drug and alcohol free, aftercare arrangements, and relapse prevention. And during this time of phase 3, you're going to be required to attend recovery court hearings monthly. So it gets down to monthly, and the group sessions monthly as well. And then you're doing your weekly journaling, therapy, certified peer recovery coach per your treatment plan. Drug and alcohol testing will be slightly decreased at random testing. And then 2 to 3 recovery meetings per week. So phase 3 really focuses on living in recovery. So the goal is to build the skills that continued sobriety, living through skills and self-discovery, relapse prevention, maintaining abstinence from drug and or alcohol, mentoring. That's a big thing that we ask for the individuals like in phase 3 is to kind of look and assist the individuals that are in phase 1 and 2. And we're focusing on daily living skills that focus on a healthy way of living during this time frame and really giving the skills for a long-term recovery. And then we get to look at graduation, a very exciting time. Requirements for graduations are as follows. So we have a minimum of 180 days, a minimum of 180 days sober, 90 days without program violation. Court assessments are paid in full. Complete the application for graduation. So once all that's turned in, handled, and taken care of, then we can have a graduation party. And when individuals graduate recovery court, we throw them a party. And they get a certificate of completion. Probation ends at that time. And it's a wonderful celebration. I feel really passionate about recovery court, being that I started my career with community mental health in the St. Clair County Jail, and I worked there for probably about a decade. And I saw individuals coming into the jail that were really struggling with recovery. And it just seemed like at that time, there wasn't a place in the court system for those individuals to appropriately, meet the needs of their addiction. And we always heard about like Macomb County and Wayne County and the other counties that had this drug court or recovery courts or DUI courts. And to see Abby and Judge Armstrong, or I'm sorry, Judge Monahan, I'm so sorry, put this court together and create this opportunity for our community it just felt so good. And it's an amazing court to come to and be a part of. So thank you. I'm sorry, Judge.
I was really impressed too, as I came on after Alexis and then met with the group at the court. They even offer one of the peer run groups right at the courthouse on the day when they're meeting for court. So it does make it a bit easier for people who are working and they're taking the day off in order to go to court. They also get one of those meetings. So it was a really nice team. I was very impressed by the team, and even with the people that are taking part in recovery court, they're sort of treated as a team too. That really impressed me when I've been there.
It's all the feel goods, isn't it? I
Mhm.
love it. I love being a part of this program. So just an ending for my presentation, I just like to kind of throw out a couple different quotes that I've heard in the last probably 6 months that really just like struck the strings for me. So here we go. My kids trust me again. If I didn't go through this, I would be dead. This program saved me. I have the best credit score I've ever had in my life, and I'm saving for a home now. It feels so good to sign a lease. I've never had my own home. This is the longest I've ever been sober and the happiest I've ever been in my life. I know I love that too. Just really get you. So at this time, I think anybody have any questions to go through for the substance use program or recovery court program? I think we're going to kind of open up to that before we get on the nurses for the MAP program. Should we go?
Just remind folks that we're having a little tech issues, but you can certainly submit your questions for Alexis and Sherry in the chat, and we'll just check right now to see if there's any questions coming up in the chat.
Right there. Okay. Oh, yes. Thank you.
We're just going through to make sure we don't have any other questions, folks, and then we'll switch over.
And thank you for letting us know the mic wasn't working right.
Mhm.
And was it Chris? He was trying to work us through it. I'm sorry, Chris. I just couldn't figure it out. Thank you.
Great. All right. So what we're going to do right now is again, just because we're having a little tech issues, if everybody would hang tight, we're going to go ahead and just stop sharing our screens for about 5 minutes. And come back at 9:35 for our nurses to go ahead and do their presentation. So again, if your screen shows nothing, we're just taking about a 5-minute break, folks. Thanks so much to Sherry and Alexis. We appreciate all the information, and we'll see you guys back in about 5 minutes. All right, folks, before we get started again, we do have a couple of questions for Alexis. So I'm going to go ahead and read them off before we put the screen over to Courtney and to Megan. One of the questions is, and I'm assuming it's for court, if it's not fitting now, if at any point would it be helpful for a person for the recovery court, is there any flexibility to the schedule? So I'll go ahead and let Alexis answer that.
Unfortunately, no, we have court every Monday, and I'm assuming that's what you mean. And it is scheduled times for court, and we do that every Monday. And then maybe you were talking about the phases too. Could be, you never know, but that's definitely set in stone as well. That's a handbook that the individuals sign and agree to, and there's a participant agreement, and that's how we roll for that.
Okay. Another question, is there any way your great programs could become more seamless and less restrictive from the get-to-go to make it easier, from the get-go to make it easier?
Our program, no, we're a contract agency.
We are a contract. Sherry's reminding me that we are a contract agency. Doug, that's an awesome question. I think as we're a newer program and this is a newer contract for the substance use department and the community mental health. We have been working on that for a few years now, trying to make it as seamless as possible. So we're doing our best. If anybody's got any feedback from community members that have gone through this process and something that might work better, but we're trying to make it as efficient as possible. Thanks for that.
Okay, great. I think that's what all the questions, and we're going to go ahead and get Courtney and Megan set up. Thanks, Alexis. All right, folks, we're going to go ahead and get started. Again, we're having a little technical issues with our slideshow. You might see 2 slides as well as the next slide, but we're going to go ahead and get going just for time's sake on this. So I'm going to go ahead and put it back over to our nurses for the presentation. All right, we have Megan and Courtney who are going to go ahead and talk about medication assisted treatment. We're just going to make sure that we can go ahead and advance their slides. All right. Which we can. All right. So I'm going to move this for you guys. All right.
Hi, everybody. Just to introduce us briefly, my name is Courtney Rosinski. This is Megan DeStefanis. We are both registered nurses here at St. Clair County Community Mental Health. We jointly run our Suboxone program that we're very proud of, and we're gonna today talk to you a little bit more about medication assisted treatment, kind of give you a brief overview of what that is, what some of the medication assisted treatment options we have here at CMH, and hopefully have a few times for some questions at the end. So we will go ahead and get going here. Maybe. So what exactly is medication assisted treatment, also known as MAT? MAT is the use of medications with counseling, behavioral therapies to really try to focus on the whole patient approach to the treatment of substance use disorder. It's indicated for opioid use disorder and alcohol use disorder. Excuse me. It works to normalize brain chemistry, block the euphoric effects of alcohol and opiates, relieve those physiological cravings, and normalize body functions without those negative and euphoric effects of that substance that they're using. So MAT is proven to be clinically effective and to significantly reduce the need for inpatient detox services for individuals with SUD. So just a quick few updates with some of the federal rules and regulations that used to be in effect. Basically over the summer, they removed the federal requirement for prescribers to have a special waiver to prescribe medications such as buprenorphine, which is also known as Suboxone, for the treatment of opioid use disorder. So any prescriber that has a current DEA registration that includes the Schedule III authority can now prescribe buprenorphine for opioid use disorder, of course, with their state law, if that they allow that. What this means is that there's no longer quantity caps of how many people they can prescribe Suboxone, buprenorphine for. So really it helps allow more access in the community with primary care doctors and other specialists in the area. And I know we've seen a lot more primary care doctors begin to start writing it due to this lifted federal requirements that they did. So now we're going to talk a little bit more about some of the medications that are included with Matt, and Megan's going to kind of go into that.
Okay, so the first medication we're going to discuss today is Vivitrol. This is also known as naltrexone. Vivitrol is the injection form of the medication, and naltrexone is the oral formulation of the medication. The injection is an extended release 4-week injection. When we're talking about these medications today, I'm going to be referring a lot to the receptors in the brain. We're nurses. This is how we know that medications work. So we're going to be talking about specifically the opioid receptor and how these medications affect that receptor and how that in turn works for people with substance use and how it treats. So Vivitrol and naltrexone are opioid blockers. So the medication comes in and it blocks the receptor in the brain completely. What that means is that it prevents opioids or other substances from attaching to that receptor. So if someone was on this medication, if they were to use alcohol, it would not attach to the receptor. If they were to use opioids, it would not attach to the receptor. Therefore, it blocks the effects of those substances used. It's used for both opioids and alcohol. This is the medication that's used for both of those things. It's used in conjunction with counseling and support. The thing about Vivitrol is that it is non-addictive and it's a non-narcotic. It's not a controlled substance. So it doesn't require a specialized program necessarily or such intense monitoring that some of the other medications would require. For this medication, it's necessary to detox from all opioids before starting, because if the medications that they're taking, opiates, for example, if they're occupying that receptor, if they were to take Vivitrol or take naltrexone, it would immediately go to that receptor and completely wipe out anything that was attached, and that would create what we call precipitated withdrawal symptoms. So they would go in immediate withdrawal. It has a very strong affinity for the receptor. So like I said, they must be opioid free. Sometimes that takes a minimum of 7 to 14 days. I guess it depends on what type of opioid they are using and the half-life of that medication. There is a risk of opioid overdose with Vivitrol if people are using opioids because, like I said, it blocks the effects of anything that's going to attach to it. So if you're on Vivitrol and you take an opioid, you're not going to feel any of the effects. This sometimes leads people to take more than what they normally would. But all those effects, that the deadly effects such as respiratory depression, are still occurring during this time. They just don't feel the euphoric effects. So this medication can't be used in people that have liver damage or hepatitis. It's very strong on the liver. So it would be contraindicated in those individuals. Not so much chronic liver problems, but more acute hepatitis. And some of the side effects are nausea, sleepiness, headache, dizziness. Mostly stomach upset is the main thing with the Vivitrol and naltrexone. The next medication we're going to talk about is Suboxone. So Suboxone is also known as buprenorphine. It is a partial opioid agonist. It also contains naloxone, which is an opioid antagonist. So what this medication does is it half binds to the receptor and half blocks to the receptor. So what that means is that it blocks the effects of other opioids, as well as gives someone the effect, a replacement effect of taking opioids. So it does give some degree of euphoria when people take it. It's very effective in that way as a replacement. Also, the purpose of the naloxone in the medication is deter individuals from using this IV. Suboxone has a ceiling effect. So that you can only go up so high in the medication and drug level before it doesn't have any higher euphoric effects. So overdose with Suboxone is very low, especially in individuals that have been using other opioids. It's indicated for treatment of opioid dependence. It helps people stay in treatment by it suppresses cravings and reduces withdrawal symptoms. It's also used in conjunction with counseling and support. And here at CMH, that's really important. We kind of have a whole person view. Our people have counseling and other services built into our programs. We like to have a disclaimer that CMH does not prescribe any benzodiazepines with Suboxone due to the potential of safety risks, including death. This is very important to us. There have been several overdoses with mixing these two medications because of respiratory depression. That's not across the board necessarily, because other doctors, they might see that the benefit outweighs the risk. So it comes individually packaged in unit doses. It's child resistant, easy to carry, and it dissolves fast and is preferred by individuals. It's placed under the tongue to dissolve. It takes about 10 to 15 minutes, sometimes longer. So people have to avoid eating, drinking, smoking, or anything like that until the medication is absorbed. Side effects, main one, constipation for sure. This occurs in many of the individuals that are taking this medication, as it would with other opioids, because blocking that receptor leads to constipation. And we do treat that along with it. It also could cause respiratory depression, physical dependence, nausea, vomiting. Some people do experience that, or runny or stuffy nose. We do sometimes prescribe Suboxone during pregnancy, only if the benefit outweighs the risk. We provide education on the different formulations of Suboxone, because there's other different types. I mean, there's Subutex, there is Subzolve. There's different types of medications that can be used that contain the same active ingredient, which is buprenorphine. And we discuss that with them. We also educate the mothers regarding neonatal abstinence syndrome, developmental considerations, and breastfeeding. But it is considered safe for pregnancy. We also do Sublocade injections here. This is a newer medication that is starting to come out more and more in the community. It is a long-acting buprenorphine injection. So it's given once a month subcutaneously in the abdomen. It can only be dispensed to a healthcare provider. Once it is in the body as a liquid, it becomes a solid gel called a depot, and that gradually releases the medication over time. So it's the same kind of side effects as Suboxone, except for people do say that the injection is painful. We do not currently offer methadone at CMH, but obviously it's a very important medication that's worth discussing. It is a full agonist. So when we're talking about that receptor, it has a very strong affinity for the receptor. It doesn't have a blocker in it. It goes on there and it goes on there strong. So what that means is that it causes more of a feeling of high than Suboxone would. It doesn't have that same ceiling effect that Suboxone has. With that, also overdose is more common because of that strong affinity to the receptor. At the sites that do it, it requires a lot of frequent visits, sometimes daily, to the clinics that do that.
So how does it work getting into our CMH Suboxone program? So if someone is not open with services, of course, they would need to call the access line and start that intake process. And then if they mention that at their intake, then that intake clinician will often do a Suboxone referral at that visit. The Suboxone referral is the first thing that kind of starts the process, whether you're in or out of services currently. If someone is in services with CMH and they're fine and they're maybe ready to take a look at that and they want help, they can mention it to their case holder or clinician, and they start that referral, which reviews a bunch of questions regarding their medical history. Have they ever been on Suboxone before on the street or from a program? Have they ever been on methadone? Are they on benzos? Do they use any alcohol? you kind of get the idea of the questions we're asking. Then that's routed to Megan and myself. We review it. We run maps to see, are they getting any controlled substances in the community over the last 2 years, just to kind of help us, give us a baseline of what's going on. Then we call the individual to come in for a MAT consult. This is where we sit down and really go through the nitty-gritty of our program. We truly pride ourselves on being crystal clear of the expectations of our program. We don't want hidden surprises for anyone, because we truly want them to find the right program that's going to work for them. Whether it's our program or not, we just want them to find the help that they need. So we go through our Suboxone requirements, and go from there. Part of some of those requirements are they can't get any controlled substances from the community or other doctors unless they talk to the team. They have to have a primary care doctor. They have to avoid the use of certain over-the-counter products. Individual counseling groups. They have to do randoms, urine drug screens, maybe a random film count. Those are just kind of an examples, few examples of some of the things that are in that agreement. If they choose to sign that agreement that day, then the next step is they provide a urine drug screen in the office. We do send it out to our reference lab, which can take 2 to 5 days to come back, just depending on if they're using a lot of substances. That sometimes can prolong the lab as they're processing that. Certain substances take longer for them to get the finalized result. Once we get the result back, we go to one of our Suboxone prescribers and present our case and try to get them linked with an appointment and get the ball rolling. Sometimes it can happen in about a week. Sometimes it takes longer. It just really depends on each individual and what their situation is and what substances they're using, because everything is very individualized for the individual.
Just a reminder that Suboxone referral can also be completed upon intake. So individuals don't necessarily have to wait to be linked with a program before we can get started on our part to get these people help. We're going to open it up to questions now. I know that that was a lot of information about the medications, and it's okay that if you ever want to reach out to us and ask us about that, you can. It's a very popular subject, so we'll open it up now to questions if you guys have any.
Do you test for kratom?
Our lab does test for kratom. It acts as an opioid, kratom does. So we definitely do test for that because it would interact with the medications that we are prescribing.
How often do you use Sublocade instead of Suboxone? Research shows that it's much more effective.
Yes, Sublocade is very effective. And the reason for that is because the drug level is more stable. So when you think about when you're taking an oral medication, so your drug level is low, you take it, it goes higher, and then it wears off and you're up and down, up and down. With Sublocade, you have a much more stable drug level in the system. We do encourage people to use the injection. It also has a lower risk of diversion. You obviously can't sell it or give it away or lose it. So we definitely do encourage that, but ultimately it's the decision of who we're trying to help, because sometimes people starting out, sometimes they need that feeling of hand to mouth that they're taking something to relieve their symptoms. And some of our people say, like, when they want to move on to Sublocade, that they're like, I really want to get past this aspect of my addiction where I have to take something, and I feel that this is the next step. Mm-hmm. So again, we try, but it's individual and it's up to everybody. We do have, I don't know, probably 10 individuals now on Sublocade. So that's, I figure, almost a quarter. So
someone had said, I've heard that Suboxone is not effective to people that are shooting up heroin. Is this true?
Well, it is not effective. If it's going to be done at the same time, that person would be very sick, because when I was talking about the receptors again, if heroin or another opioid were occupying that receptor and they were to use Suboxone, which contained that opioid antagonist in there, it would immediately make them very ill. But it is effective for people once they come off of it, but they do have to go through a period of withdrawal in order to start.
Oh, is there any way if somebody's coming into intake that they can get medication that day?
No. So it is a process. You have to be linked with services here, and we have to do our due diligence to make sure that things are done safely. And when I say that, I'm talking about avoiding that precipitated withdrawal symptom. We are looking at everything. We are not going to prescribe the medication if they're receiving benzodiazepines or other medications. The medications could cause overdose. So again, we do that very safely. That means that there's a process. And again, it all depends on when someone is also able to see a doctor, and that's not immediate. It's not immediate anywhere in the community where you can just walk in and have the prescriber have an appointment for you. So our situation usually could take 2 weeks, is about average as to when someone would be able to receive medication.
All right, thank you so much. Thanks so much,
Thank you all.
Megan and Courtney. Thank you, Sherry and Alexis. We super appreciate it. Thanks for all of you today for your patience with our tech issues. We greatly appreciate it. Just to remind everyone, the Recovery Summit continues to go on. We're ending it next week, so we have some great sessions coming up. Our next session is Monday at 10 a.m., where some of our local law enforcement is going to be talking about drug trends, the drug task force, and just different things that they're seeing locally and statewide. Just a reminder to everyone, when the webinar ends today, a survey will pop up. So please fill that out. Our presenters and our planners of the Recovery Summit love to get your feedback. And just as a reminder, if you requested any professional CEs at the very end, about 30 days after the Recovery Summit is concluded, about the end of October, you will be emailed one sheet with all of the CEs on one sheet for you. So be looking out for that. And thanks everyone, and have an awesome Friday.